response reads, yeah. So which of the following statements regarding amiodarone for the treatment of cardiac arrhythmia is correct? The following statement regarding amiodarone treatment of cardiac arrhythmia is correct. A, the mean terminal half-life of amiodarone is 6 months. We're looking for the correct option in this question. B, among patients with systolic heart failure, amiodarone is of comparable efficacy as ICD in the prevention of sudden cardiac death. C, corneal deposits develop in less than 10% of patients who are treated with amiodarone for more than 6 months. The hyperparathyroidism is a known complication of long-term amiodarone therapy. Please, if I'm not audible at any time, please let me know.
Okay, we will let you know, but you are very audible.
Okay, thank you, sir. The E, amiodarone-induced pulmonary toxicity may develop within the first week of therapy. Okay, so as not to waste our time, we are looking for the correct answer. So for option A, although amiodarone is said to have a long half-life, but is within half-life is around a week, is not 6 months. The half-life is not, so that one is false. Amiodarone use in systolic heart failure is inferior to using an ICD. It does not reduce mortality or sudden cardiac death in patients with systolic heart failure. So ICD is still set to be the standard therapy for patients with systolic heart failure. Okay, so that one is false also. Corneal deposit is said to be seen in about 80 to 90% of patients on amiodarone therapy. So the option of less than 10% is false. And the way you see the corneal deposit is when the patient is put on a slit lamp, they are likely to see deposits. Okay. For option D, it is hyperthyroidism that is related to. We all know that amiodarone contains iodine, and that's been shown to be cause of hyperthyroidism. And amiodarone can also be associated with hypothyroidism, which we call the Wolff-Chaikoff effect and Beach-Jones effect for hypo and hyperthyroidism respectively. Okay. Amiodarone, yes, can induce pulmonary toxicity and even pulmonary fibrosis, even as early as 4th week of the therapy. And pulmonary fibrosis will be seen in the long term. Hello? Hello?
Yeah,
Am I still?
you.
Okay.
Yeah, you're audible.
Okay. So the correct answer is D. So I don't know if we have anything to clarify about that. Dr. Ajayi, Dr. Tony, Dr. Adebowale. Dr. Adebowale, you are really welcome.
Thank you, sir. We hear you loud and clear.
Okay, sir. Do you have anything to clarify in that question?
No, sir. It's good.
Okay. Okay, so we can move on.
Thank you. I apparently just came in. I didn't follow, but I would listen to the recording so I don't draw us back. Thank you.
Yeah, we just started actually.
Yes, I wasn't following the what's it called discussion then. I logged on, but I quickly stepped out to do something. That's all.
Okay, so we just answered question 221.
Right.
And the correct answer, we started with question 221, so that's what we just answered. And the correct answer is D, that amiodarone toxicity, pulmonary toxicity can be seen even in the first week of starting the therapy, while pulmonary fibrosis will be seen in the long term, but they can have toxicity, toxicity even the first week. We said that amiodarone half-life is within weeks. But the option A is within weeks. The half-life is not 6 months, although it has a long half-life, but it's within weeks. Then we also said for option B that amiodarone is inferior to preventing mortality compared to ICD in patients with heart failure with reduced ejection fraction, that means systolic heart failure. So amiodarone is not of equal efficacy or comparable efficacy. So that's false, okay? ICD is still the standard in preventing mortality. We said that option C, that amiodarone causes corneal deposits in 80 to 90% of patients. So a lot of patients on amiodarone have corneal deposits. So less than 10% is false. It's far higher than that. Then we said option D, that hyperthyroidism is a complication, not hyperparathyroidism. We all know you can have both hyper and hypothyroidism, not parathyroidism. Okay, so the correct answer is option E, that amiodarone can induce pulmonary toxicity even within the first week of therapy. Okay, so we can move on. So question 2. Okay. So question 222. It said, which of the following statements regarding the mechanism of cardiac arrhythmia is correct? Which of the following statements regarding the mechanism of cardiac arrhythmia is correct? So I'm looking for the correct option. So A, in the common form of AV nodal reentrant tachycardia, that is AVNRT, anterograde conduction occurs down the fast pathway. Look at the option again. In the common or typical form of AVNRT, anterograde conduction occurs down the fast pathway. Dr. Kofi. Not shared with us.
Hello, sir. I'm with you, people, sir.
Okay. If you like that place today,
It's a passing by area. My boss put me out.
okay.
Yes, so I'm trying to. So I don't want to distract you, but that's why.
So let's let you rest.
Okay.
Dr. Kofi, sorry. So Dr. Ajayi, sir, or Dr. Ugo, is to answer that question. Okay, since there's no response, I think I should just continue.
So I can try.
Yeah. So what do you say, Dr. Tony, Professor Tony?
So I just want to try to manage the device so that I don't cause background noise.
You sound distant too.
Yes, I'm trying to. Okay, can you hear me?
Yes, sir.
Which of them are you hearing now? Am I clear?
Yes, sir. You are very clear.
Okay. So, question said, we're looking for which is correct. Which of the following statement regarding mechanism of cardiac arrhythmia is correct? So the common form of AV nodal reentrant and anterograde conduction occurs down the fast pathway, slow pathway, not fast pathway.
That is it.
You use the fast pathway. That's what you use it to go back to depolarize what's it called, typical form. I'm sure that's what they refer to as the common form. So it's the atypical form that will go through the fast pathway.
So trying to re-emphasize that I want to repost that thing we discussed. If you remember what we discussed on the mechanism, I'm reposting it back to the group.
Okay.
I've reposted it back to the group. We can see it now. Hello? We can see it, right? Dr. Tony.
Yes, yes, we can see it. I can see it.
Okay, so you can see that it is the slow pathway. You can see that it's the slow pathway, the one that is the line that is curved. If you open that in I posted, you will see the slow and fast pathway. You can see the direction of the arrow of the slow pathway. That's the guy that brings it to the ventricle. If you look at the one to your right-hand side, it's the slow pathway that brings it to the ventricle, while the fast pathway takes the circuit back to the atrium. So that option A is false. Dr. Ugo, hope is clear. Yeah.
Yes, sir. It is clear, sir.
Okay, Chief Ajayi. Okay, so
Thank
that
you,
option is false. So that is the typical form of AVNRT. If it's the atypical form, then it is vice versa. Fast pathway will bring it down to the ventricle, slow pathway will take it back to the atrium. So the person that brings it to the ventricle is the anterograde conduction. The person that takes it back to the atrium is the retrograde conduction. Okay. So in option B, it says in autodromic AVRT, that means AV reentrant tachycardia. This is AV, no, AVRT, not AVNRT. In AVRT, the activation wave travels via the accessory pathways to the ventricle, then retrograde via the atrium to the atrium. Dr. Ajayi, true or false? Dr. Okay. Dr. Austin, true or false?
I think it's true.
Okay, you think it's true. Okay. All right. So can you quickly explain to which one are you going for? True or false? Sir? Because I'm hearing false, I'm hearing true.
False.
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 Okay.
It's anadromic that is that goes through that and through the accessory pathway, the bundle of Kent, but for anadromic, usually goes through the it goes through the AV node, yeah. Why the reversal, the antidromic is what passes through the accessory pathway.
This is more like antidromic AVRT. That's the, I mean, it should have been antidromic AVRT. That's explain what they just explained. So autodromic will pass through the normal from the ventricle to the atrium and then through the AV node. That's why it's concealed. That's a masquerader. That's why we mimic AVNRT.
Okay. Thank you, Chief Tony. Thank you, Dr. Bernard. So let's go to the group. There's an image I posted on the group to re-emphasize what Chief Tony and Dr. Bernard have said. Can we go to the group?
Dr. Bina, your network is poor.
So this is for
Chief, I can't hear you again. No?
Yes. Chief Ajayi, can you hear me, sir?
Okay, now I can hear you, sir.
Okay,
It's
sorry
network.
about
It's
that.
raining here.
Yes, sir. So, can you see the image I posted on the group, sir? Hello? Chief Ajayi? On the WhatsApp group. Dr. Tony?
Yes.
Yes, we can
Okay.
see what you posted on the WhatsApp group.
Okay, so you can see that of if you zoom into it, if you open that image and zoom into it, you will see that of orthodromic on your left hand side. And on your right hand side, you can see antidromic, right? Chief Ajayi, you following?
Yes, I'm with you. I can see the diagram.
Yes, sir. So you can see for the orthodromic that yes, the arrow is, if you look at the AV node, you can see the arrow coming downward.
Yes.
So meaning that the wave is coming from the atrium through the AV node, through the bundle of teeth, and through the right and left bundle branch, right?
Yeah.
And it is going to return back to the accessory pathway. The accessory pathway, you can see, if you look at the left ventricle, around the mitral valve there, the lateral annulus of the mitral valve, you can see the accessory pathway there. That is taking it back to the atrium, following the arrow.
Yeah.
And in orthodromic, you can see that if you look at the ECG below, you notice there is a narrow QRS.
Yes, it is.
Yeah, it's narrow because the wave
following the
that is
normal.
depolarizing the ventricle is passing through the normal conduction fiber, right? It's clear, Abby?
Yes, sir.
Now, so let's go to the antidromic, the one beside. You just shift your screen to the one beside it. You notice that the impulse or electrical wave is going retrograde upward along the AV node.
Yes.
You can see there, and that is a retrograde fashion.
Yeah.
And it returns, so via the atrium, it goes to the accessory pathway, and accessory pathway carries to the ventricle. Then the east Purkinje system carries it to the AV node back to the atrium in a retrograde version. So that's why the QRS is broadened. You understand?
Yes, sir.
So that means we can go back to the question now, right?
Yes.
So we're looking at question 222B. He said in orthodromic AVRT, that means orthodromic tachycardia, the activation wave travels via the accessory pathway to the ventricles, then retrograde via the AV node to the atrium. So is this true or false? For orthodromic. I think my network is poor. Dr. Ajayi, what do you think?
Well, Chief, it says in orthodromic AV reentrant tachycardia, the activation will travel via the accessory pathway to the ventricle. That part seems to be true. Then retrograde via the AV node to the atria. Retrograde via the AV node to the atria. I'm trying to process that. I know the first part of that statement looks true, but the issue of retrograde.
Look at the picture again in the WhatsApp group. Scroll to the picture again in the WhatsApp group.
It's false.
Okay. Orthodromic Orthodromic, I see it's coming from the SA node, at least for the atrium. It enters the normal AV node. Actually, I can see it entering this Purkinje system to polarize the ventricles. So the activation wave travels via the accessory pathway to the ventricles. That is true. Then retrograde.
Wait.
That retrograde via AV node. Wait.
Okay, I look at it very well.
There's the one on the left now, on the left of my screen. The arrow
Where's the
emerges
arrow?
from the atrium, from the SA node, supposedly. It goes
The arrow
down.
is not SA node anyway.
It's not
It's
the
the
SA node.
reinforcement circuit.
Okay,
You cannot. You know where SA node is now? It's on the right atrium, upper part of the right atrium.
Yeah.
Any arrow coming from there.
Okay. So this arrow that is sitting, this ovoid mass that is just above the mitral valve. That white one that the arrow is sitting
That's AV node.
That's AV node.
The one above which valve? Tricuspid valve.
Yes, thank you, Jerry. Tricuspid. Even like the hunger, they worry me. Yes, the one above the tricuspid valve.
That's AV node.
Okay. So the wave is coming from the AV node. It polarizes the ventricles. Then it goes
in what fashion?
retrograde.
Wait, in what fashion? It's coming from the AV node to the ventricle. In what fashion? In a retrograde fashion or an antegrade fashion?
It's coming from the AV node to the ventricles in an antegrade fashion.
So look at the question again. Look at the first part of the question again.
Okay, it says in the orthodromic AV rental certificate, the activation wave travels via the accessory pathway to the ventricles. Then retrograde via the AV node to the atrium.
Recording in progress.
It looks true now.
From the picture of what we are seeing, Dr. Ajayi.
Now, Chief, the wave is coming from the AV node. It goes down to the ventricles, it polarizes the ventricles, it flows from the ventricles back to the atrium.
True what?
In a retrograde fashion now.
Wait, through the accessory pathway or through the AV node?
It's going to it's through the accessory pathway now.
Yeah. So that means it's going through the accessory pathway to the atrium. Is it going through the accessory pathway to the ventricle or to the atrium? Okay, the picture is clear. Look at the arrow, the accessory pathway. Is it taking it up to the atrium or is it taking it down to the ventricle? Follow the arrow. The accessory pathway is
taking it up to the atrium.
Through the accessory, because the accessory pathway is labeled.
Maybe the accessory pathway is the yellow one.
It's labeled, now the arrow is there, the label, accessory pathway. Open, if you see the so is it taking it to the atrium or is taking it to the ventricle?
It's taking it to the atrium.
So look at the question again.
In orthodromic evidence, the activation wave travels via the accessory pathway.
That's what we need you to see. Just look at the question very well and see the picture.
Your eyes are open.
Chief, don't mind me. Try.
Okay.
It's false. I can't believe I fell for this. Okay, Chief, thank you. The rescue package. Thank you, sir.
Okay, in most patients with Wolff-Parkinson-White syndrome, the accessory pathway conducts more rapidly than the normal AV node, but takes longer to recover excitatively, to recover excitability.
It's true. You said that now the last time you were talking.
Yeah. So the accessory pathway conducts faster.
More rapidly, yeah,
Yeah.
than the AV.
But it takes longer to recover.
Yeah.
Okay. D. Abnormal automaticity is the most common mechanism of atrial flutter. True or false?
Re-entry.
It's
false.
re-entry now.
Re-entry on the right.
Yeah, exactly. Exactly.
How
All forms of ventricular tachycardia arise from abnormal automaticity. True or false?
False.
False.
All forms.
Oh, na lie.
Lie.
Thank you, Dr. Ladwiji.
Question 223. A 14-year-old boy suffers 2 episodes of sudden syncope during gym class while jogging and is referred for further evaluation. His paternal uncle had died suddenly during physical exercise at age 20. Laboratory evaluation includes an ECG that shows normal sinus reading with normal QTC interval. Cardiac MRI reviews a structurally normal heart. CT angiography demonstrates normal coronary anatomy. He undergoes treadmill exercise and the reading displayed in figure 2.7 is noted after 3 minutes of exercise. So what is the first line treatment for this condition? So let's look at the figure 2.7. Figure 2.7 is the next page. So this is the treadmill ECG and it's labeled the timing. You see at 3 minutes of exercise
and 5
and at
minutes.
5 minutes of exercise.
Yes, sir.
So, Dr. Ugo, what do you make of this? Dr. Duduyemi, you're highly welcome. We have been missing your authentic stuff.
Good evening, sir. Thank you, sir.
Welcome, ma'am.
Dr. Julius, as to wake up.
Okay. Good evening, sir. Good evening, everyone.
Good evening. So, Dr. Ugo, are you with us, ma? Okay. Dr. Chief Julius, what do you think of that treadmill?
Well, I can see there appears to be multiple PVCs.
Okay.
Yeah, that's true.
Yeah, multiple PVCs.
So, what you are interpreting now, is it the 3 minutes you are interpreting or the 5 minutes?
Yes, it's 3 minutes.
The 3 minutes, okay, fantastic.
Yeah, so the 3 minutes I can see multiple premature ventricular complexes.
Okay, fantastic. So let's look at the 5 minutes then. So what can we make of it now?
Okay.
It's easy to call it artifact, right?
This one is not artifact, though. Get a CP.
These are certainly ventricular readings.
Yeah, especially when we had that at 3 minutes to have a different methodology of PVC at 3 minutes. So at 5 minutes, it can't be an artifact per se.
Yeah.
Okay. So there's still a lot of premature ventricular complexes.
And they are polymorphic.
Yes.
morphologies are different.
It appears to vary. Yeah, I think.
Okay, fantastic. Thank you, Dr. Ajayi. They are polymorphic. So with that in mind, if you now look at the history again of the patient, the young guy, the 14-year-old, look at the symptoms he has had. 2 episodes of syncope during classes, during his gymnastic classes. His uncle has also died at the age of 20. So that should send a strong information. I'm sure he'll have died of sudden cardiac death because they didn't say he had an accident at the age of 20. So with this ECG finding, normal cardiac MRI, normal CT coronary angio. In fact, they said his baseline ECG was normal. You remember?
So it was exercise that brought out all this anomalies.
Exactly. So it's the treadmill exercise. So what do you think would have been your diagnosis?
It's like exercise induced.
Yes.
Fantastic. So that is the so in our simple language, it's catecholinergic VT.
Okay.
Why? Because it only
That
comes
makes
up.
sense. Rest is normal. So okay,
Exactly.
CPTV.
With a normal QTC. So he didn't have a long QT syndrome.
Yeah.
Okay.
Yes.
So it can only have been brought up by exercise. And the time he had the syncope too is actually doing exercise.
Okay. Yeah.
So this is a cardiogenic VT. Okay. So they said, what would be our first line of treatment then? Should we give magnesium? Should we put the patient on dual chamber pacemaker? Or should we do beta blocker and ICD? Or we do exercise training with adequate hydration? Maybe dehydrated during exercise. Or do cardiac sympathectomy and innovate everything. So what will you go for? Okay,
I'll go for beta blocker.
I'll go for C.
Yeah, I know it's not magnesium is more for that long QT.
Don't say the points.
Exactly. So this is not TOSAT. Then dual chamber. That's like biventricular. No, it's not.
You will just
beta blocker. Yes, he has tachycardia.
And the fact that it's also
no, if he cannot even tolerate exercise, cardiac sympathectomy. I don't know about that one. I suspect C.
Yeah, so you see, don't worry, that's the answer. C. So you put on beta, that's treatment for cardiogenic VT. So you put an ICD, also put patient on beta block. Okay, so we can move on now.
So, do they do cardiac sympathectomy for people at all, or this is just a red herring question? This option B.
You don't do cardiac sympathectomy. It's renal denervation they do.
Yeah. Renal hypertension. Yeah. Okay. Thanks, Jake.
Okay. Question 224. Say 72-year-old man with non-ischemic dilated cardiomyopathy with EF of 38%, NYHA class 3, and chronic kidney disease, creatinine of 2.8, present with symptomatic paroxysmal atrial fibrillation. ECG, when in sinus rhythm, shows a corrected QT interval of 442. Okay. Which of the following is the most appropriate initial oral antiarrhythmic regimen to maintain sinus rhythm in this patient? So get the question again. Which of the following is the most appropriate initial oral antiarrhythmic agent or regimen to maintain sinus rhythm in this patient. We look at his clinical features again. 72-year-old man with DCM, EF of 38, NYHA 3, and he has background CKD with atrial fibrillation, proximal atrial fibrillation. So, which therapy will keep him in sinus rhythm? Or that will maintain him in sinus rhythm. Okay, A, outpatient initiation of dofetilide, 250 micrograms twice daily. Outpatient initiation of sotalol, 120 milligrams twice daily. Inpatient initiation of disopyramide, extended release, 200 milligrams every 12 hours. Or inpatient initiation of dronidarone, 400 milligrams twice daily with close ECG monitoring. Or E, outpatient oral amiodarone, 200 milligrams three times daily for 2 weeks, then followed by 200 milligrams daily. This is Jai's field.
Wow, Chief. Initial oral.
I'm sure Dr. Kiala will not say this kind of reason for it.
Dr. Akon, I salute you. Dr. Finney, I salute you. Okay. So what do you think now, Chief Ajayi, since you have held on to the question?
Chief, let's give this man another round.
What? We should do what? Well,
someone's background is howling.
But he said, let's give this man amiodarone.
Okay, amiodarone.
I think we
why
should.
not drodarone? After all, they are related.
No, a patient that has left ventricular systolic dysfunction, you don't give. In fact, it's increased mortality.
You don't give. Yeah, that's one of the reasons.
Yeah. So you not give dronidarone to someone with impaired left ventricular function.
Yeah.
Okay. All right. So that's the treatment. E is the appropriate treatment. Others are not suitable. Okay. So we'll go to 225. Now, so a sample tracing from an EP study in a patient with narrow complex tachycardia is displayed in figure 2.8. What is the diagnosis? So, Dr. Tony, you've projected this one, Nari. Yeah, you have a question, huh?
Yes, I'm sorry. I just I agree that amiodarone is correct.
Yes, madam.
With it is apparently the dosage.
Which I didn't get you clearly. Which what?
I agree that amiodarone is apparently correct, but the struggle I had with it was the dosage.
Dosage, okay.
I thought that it was going to be a further thing, 200 milligrams thrice daily for it's 2 weeks, not I thought it was 3 weeks. I'm sorry, the error is mine. I'm not using my glasses, so I thought it was 3 weeks. I saw.
It's 2 weeks.
Thank you.
Okay, ma. So we already question number 225. So they've given us an issue. Said they've given us a background information before we start looking at the EP. It said this patient has narrow complex tachycardia. So they now did EP for the patient. So they want us to now make. So Dr. Dudu Yemi, the EP madam. Dr. Ugo. Dr. Ugo, welcome on board. Dr. Ugo, welcome on board. Help us look at that EP tracing. Chief Tony, the EP tracing is there now.
Yeah, it's there.
I think we can all zoom through our phone. We can zoom our phone. Huh? Chief Tony, you'll be using your arrow. Okay. All right. So before we look into it, let me just quickly describe what is on that EP. So Chief Tony,
Yes.
let's start from we remember with the tracing that we have first. Let's analyze the tracing from the marker. So we have the surface ECG, which is showing us lead 1, lead 2, lead 3, and V1.
Yes.
Okay. So Dr. Ajayi, were you with us when we were doing the CP class?
Chief, I was half there.
Okay, but you'll have reviewed the videos now.
Yes, I've been doing that. Chief.
Okay. Okay, great. So the RA is the right atrium, right?
Right atrium.
The HBE is there's a catheter in the right atrium. Then there's another catheter that they placed in the east bundle, HBE, okay? And there's now another catheter in the CS, that means the coronary sinus.
Coronary sinus.
Okay? Now, so if we said that anytime you are referencing, it's best to reference, your reference catheter should be the east bundle catheter because it can show the atrial tracing, it can show the east tracing, and it can show the ventricular tracing.
Yeah.
Dr. Tony, remember?
Yeah.
Yes.
Okay. Yeah, Dr. Tony, you are still with us, sir.
Fully with you.
It's with us, sir.
Dr. Tony.
I'm fully with you, sir.
Because I need him to move this out. I'm not hearing.
I'm fully with
okay,
you.
Chief. All right.
He's responding.
Okay, so you can see they've labeled most of the time you will not see this label, you know, but they have helped us with the label. So we can see the A. Let's focus on the east catheter. So Chief Tony, you can move your arrow there to the east catheter, yes. So we can see the A. The A means atrial activity. Okay. The H means east bundle activity. That means the polarization of the east bundle. That means the electrical activity have reached the AV node and the east bundle system at that time. And the V is the ventricular depolarization. And you can see that the V corresponds very well to the QRS on the surface ECG.
Yes.
So just emphasizing that QRS, which is ventricular depolarization, the same thing you're seeing as the V in the intracardiac activity.
Electrogram.
The V. So you can see that you can use your east catheter as a reference catheter for detecting activity of the atrium, detecting activity of the east bundle, and the ventricle at the same time. You get it, sir?
Yes,
so
sir.
This is what I want us to notice. Look at, you can see distinct wave between the A and the H. They are separate, right? Then you can see that the H and the V too is separate.
Yes.
You notice that?
Yeah.
Okay. Hope I'm still audible. Hope I'm well audible.
You are very
My
audible,
network
sir.
is fluctuating.
Yeah.
I'm audible, Dr.
Good
Ajayi.
evening.
Yes, sir. We hear you loud and clear.
Dr.
Welcome,
Ugo.
Ugo.
Okay.
I'm fine. Awake now.
You are awake, Ugo.
You are awake,
Take
okay.
hot water. Rub
I'm fully awake now.
So, Dr. Ugo, you didn't greet me. Okay.
I didn't do what?
You didn't greet me.
I didn't do what?
You didn't greet me. It's not fair.
Somebody's background is making noise, though.
Dr. Kobe.
That's okay, sir.
Oh, you said you didn't greet him. That's not
She is
fair.
so
Okay.
passive.
Oh,
So
sorry,
let's
my
move on.
dear. Good evening, Dr. Coffee.
Okay. Laugh. All right. Yeah, so we can see the distinct. So for the fourth cardiac activity, Dr. Tony, you can help us circle the first cardiac activity. That means the AH, the first set. Yeah, so everybody is following.
Yes.
Just circle around it. So you can see the AHV,
Yeah.
the first cardiac activity. That means you can see they are separate. That's the normal you expect. That means that the SA node activity occurred before the EASE activity, before the ventricular activity, right? For the first cardiac activity. Abi,
Yes,
that's
sir.
what you expect. It should
Normal.
come from wave should come from the atrium to the EASE, then to the ventricle. That's
Yeah.
what you are saying there. So if you go to the second cardiac activity too, we are seeing the same thing,
AHP also.
right?
Yes, sir.
Go to the second one, Dr. Chief
Yes.
Tony.
I'm
See
there.
we are
It's circling
focusing on
around
the
it.
EASE catheter.
Yes.
So you can see the A,
H
you can see
and
the
D.
H, and you can see the ventricular activity, right?
Yes.
Yes.
You can see that it looks like the expected normal one, right?
Yes.
So immediately after the ventricular activity, you will notice that they gave us another A,
Yes.
right?
Yes.
And you notice that that A is not related to any H, neither is it
Yes.
related to any B,
Yes.
right?
Yes, sir.
It's on his own.
Okay. Yes, we'll tell you what happened there very soon. So then when after that, the cycle that now followed, you can see that everything is meshed together. H, A, V, everything is
They're
occurring at
all
the same time.
crowded. Yeah.
Yeah.
They're crowded. The one after that too, H, A, V, everything is occurring. That means the same time you are getting atrial activity, the same time you are getting ventricular activity and the EASE activity at the same time.
Oh, wow. Yes, sir.
So, but you notice that they said that the EASE AV node activity is like slightly before atrial and ventricular activity. If you notice, the H is coming first from the labeling.
Yes.
Then you now see A and V meshed together, but H is coming first.
Ah, yes, so that's
So
true.
we'll explain what really happened. So you will notice there that it seems the guy that is generating the wave is now in the H, in the
Yes,
AV
like
node
the
EASE complex.
Yes. It's driving both.
And at the same time, it is despolarizing the atrium and the ventricle.
And the ventricle.
At the same time, fantastic. Okay. So with that little information, Dr. Ajayi, what will have been your diagnosis?
It's all those.
And if you remember, they said the
reactants,
patient on the normal ECG had a narrow complex tachycardia.
narrow complex. Narrow complex. So I'll go for, let me see.
Yeah, it's the entrant at.
I think
AV node.
Fantastic.
Yes,
So
because his bundle disease is either below or at the level of the AV node.
Because the H is,
so you can see that the H activity is occurring
for A and
slightly earlier. Yes, it's before A. So it means that it is sending a wave to the atrium and sending the wave to the ventricle at the same time. Dr. Ibo.
Chief, we're with you.
Chief Tony, am I still audible?
Yeah, very audible.
Okay.
Yes, sir.
All right. So this, and with a narrow complex tachycardia, this makes it an AV nodal. reentrant tachycardia.
Okay.
AV node reentrant tachycardia. So anytime you are doing an EP and HAV complex is occurring at the same time, meaning that you are depolarizing the same time you are depolarizing the AV node, the same time you are depolarizing the atrium and the ventricle, then that is the AV nodal reentrant activity. Because all the complexes are occurring in the AV node. Okay, I hope that is clear.
Yeah, Chief, just before
Now,
you go. Chief,
remember we said that
Chief,
Dr. Kweki is asking something.
Chief, just a question. In a case where these things are not
Yes,
labeled for us, A, H, and V, how do you decipher that this is atrial, his, and ventricular?
Why would they not label it? That would be wicked.
Even if they don't label it, you look at the surface ECG. Apart from that, you also
so that I will tell you.
the surface ECG is the guide. The surface ECG is the guide.
Hello.
I can hear you.
Okay, so this is what will happen. This is how you get to know. I want you to notice something. Look at the RA catheter.
Right atrium, yes.
Yes, you can see that it's only giving one wave only.
Yes.
Are you getting it?
Yes.
Then the CS catheter, coronary sinus catheter, is meant to give you the ventricular lead also, because as I said, it's closer to the left ventricle. Now, this is one thing you should now notice again, is that apart from the merging of the, so first, let's go to the ones that are normal from the first cycle, you can see that the RA wave, you can put your arrow, doctor, yeah, RA wave, the A wave there, you can see it corresponds. Dr. Tony, go to the normal one, the first cycle.
This one.
Yes.
Yes, you can see the atrial activity there, right?
Yes.
Yes.
You can see it corresponds with the atrial activity of the East bundle. Can you see?
Yes.
Yes,
all right,
it does.
good.
They are similar.
Yes. Then you will see an H, which is not represented on the atrial on the RA.
Yeah.
Right? And the V, which is also not represented on the RA, but is represented on this coronary sinus catheter.
Yes.
Are you getting it?
Yeah.
So telling you that the right atrial catheter will not record East activity, the East bundle activity. It will not record ventricular activity. It will only record atrial activity. Are you getting it, Dr. Tony?
Yes.
Yes, sir.
Now, if you now go to the third cycle where they were merged together.
Yes.
You can go to the third cycle. I'm looking for your arrow, Dr. Tony. Sorry, I couldn't use my laptop because of electricity. No, the third
one.
cardiac cycle,
On the HBE line.
The next one, Tony.
This one.
Yes. So you can see the atrial activity, right?
Yeah.
Okay. You can see that under the East bundle activities, East bundle catheter, you will see an activity occurring before that atrial activity, which represents the H. They label it H, but you can see it's occurring before the RA activity.
Yes.
Yes.
Good. And you can see the CS. Look at the CS activity, coronary sinus activity. You can see that it is aligned as a straightforward, it's like on the same plane with the right atrium activity.
Yeah.
So if you use, normally they're supposed to give you RV catheter too, but since the CS is representing the RV catheter, that's right ventricular catheter, that means that the same time you are having right atrial activity, RA, is the same time you are having coronary sinus activity, CS.
True.
So that means, and you can see the right atrial activity. One last thing is this, look at the surface ECG. One last thing, Dr. Tony, look at the surface ECG for that same side. You will see the right atrial activity, RA activity. Come to the catheter, the RA. The RA, you can see it's corresponding to the same time of QRS complex of the ECG, of the surface ECG.
Yes.
So that means the same time you are depolarizing the right atrium, at the same time QRS is occurring for the ventricles.
Yeah.
Can you see it there?
Yeah, exactly.
Yeah.
So it's telling you that atrial and ventricular activity is occurring at the same time, which is what we described when we're discussing the mechanism of AVNRT. If you remember in that recording, if you check the recording when we're discussing the mechanism, the same time you are depolarizing the atrium, the same time you are depolarizing the ventricle. Why? Because we throw it back to the atrium. So that is why it's everything occurring at the same time.
Yes, sir.
Yes.
So Dr. Ajayi, hope is.
Yes, sir. That helps a lot.
Okay, it's clear. But before you go again, I have one more stuff that I need to talk about. When we do our normal surface ECG, the shape of your complex is important, including your atrial activity. But apparently, for what we have gotten so far, the shape of the atrioventricular, their shape is irrelevant. It's just the activities we're interested in. I don't know whether you got what I'm trying to say. Hello,
Chief Dimeji. Chief Dimeji, did you hear him?
We've lost him.
I think we've lost him.
Okay.
That's a very important observation. We need to hear what Chief has to say about it.
Because apparently all the time we are talking, we don't talk about
He's back.
shape. We just talk about the activity. Okay, Dr. Oladimeji, what?
Oh, I don't know, and I went to create a web link. Sorry.
Oh, did you get my question?
Dr. Tony, you said something, sir?
Did you get my question?
No,
Your question.
Dr. Oladimeji did not hear your question.
Okay, I was trying to say that if you usual surface ECG, the shape of our ECG, P-wave, carrier complex are important when you are making diagnosis. But I observe that since we'll be talking, we don't talk about the shape. We just talk about the atrial activity, his activity, and all that. So is it that the shape is irrelevant or just the activity that we are concerned about?
Okay. You mean the shape of the catheters in the ventricle or surface ECG?
Shape is the catheter, the EGM, the shape of the
DGM.
Yes.
The shape of the EGM.
Yes.
Technically, it might not really matter. It depends on how you filter the catheter. It depends on filtering of the catheter. As I said, there's a lot of things they do in that EP to filter the kind of activity on the catheters, so that there's no one shape that will say that this is ventricular shape or this one is atrial shape. No, I can filter that catheter there. That V, we are saying will look like A, depending on the level of filtering I put on it. And I can filter the catheter that the A you are seeing will look like a V. You get? So the only best way is to look at the catheter and the electrical activity you are generating on the catheter. That's why we're trying to emphasize the catheters, that the right atrial catheter will not sense the ventricle, neither will it sense the east bundle. So the only activity you're going to see in the right atrium catheter will be only atrial activity. We try to emphasize that when we're discussing it. And also said that if the catheter is in the right ventricle, if you see an RV catheter, it will not sense east bundle, neither will it sense atrium. The only activity to be showing you will be what? Would be right ventricular activity. You still see that when we look at other EP, there are still more EP to look at, but you're just trying to emphasize that the shape does not really matter. It is the activity is generating and which catheter that you are looking at that matters. That will help you look at what is really happening. Okay, sir?
Yeah, so it gets very clear. Then the next point, don't mind me, I have a lot of points today. The next point is when we're trying to differentiate AV nodal hereditary tachycardia and AVRT. Remember we said, especially the conceit type, the orthodromic type. You know, once the patient is out, we are taking your surface ECG record. When the patient is having episode, difficult for you to say which is which, except you have sinus reading. You know, you convert them to sinus reading before you can say, because of a short PR interval in orthodromic. Now, using the EP, I know we don't have EP tracing for orthodromic AVRT, but assuming we have one, can you use this one to explain?
No way.
Is that
There's a tracing for it.
There's a tracing.
Don't worry. There's a tracing for it.
Okay. I'm clear. That's all.
Then when we get to that tracing, I'll show you. Then we'll bring up this image back.
Okay.
And compare the two. But one thing I also want you to notice that, remember we talked about the AH interval.
Yes.
Right?
Yes.
I will set it around
65, 125.
And we talked about HB interval. Right?
35, 55.
So you will notice that in the first two cardiac cycle, you can actually get some interval between them, right?
Yes.
But in the fourth or fifth cardiac cycle, you cannot actually tell if there's any interval. They're all matched together.
They're all matched together, yes.
So anytime VA duration is equal to 0, then it's AVNRT. Meaning that the interval between the atrium and the ventricle, if it's equal to 0, then that means that atrial and ventricular activity are occurring at the same time. Do you get it, Doctor?
Yes, get it. AVNRT. Yes, clear.
Because you expect there should be an interval between AH. There's an AH interval. There's an HB interval, right? That means there will be an interval between A and V. Are you getting it? So we are not saying that if the interval between A and V or V and A is equal to 0, that means that the atrial and ventricular activity is occurring at the same time.
Yes.
You get it, Dr. Ajayi?
Yes, sir.
And that's what we are seeing here. If you look at the RA catheter in the fourth cardiac cycle and the CS catheter,
yes,
you will notice that they are occurring at the same time.
At the same time. So it's an AVNR.
So atrial and ventricular activity is equal to 0. The interval is equal to 0. So that is AVNRT for you.
So, Chief, if it were AVRT,
what will you see? Have you?
Yes, sir.
Okay, I will show you what you will see. I just want you to remember the mechanism. If you still remember that mechanism I described about the fast and slow pathway, it will help us demystify these things very well. If you still remember it, Dr. Tony, so that or you want us to go back to it?
No, I remember very well.
Dr. Ajayinko?
Chief, just proceed. I will catch up with that video.
Okay.
I will. Yes, sir.
Okay, you know one thing, just for one reason, for one sake, because of time, I want you to go to the group. Look at the the one I posted before the last one. The AV node re-entry. Can you see it, sir? You can see it.
The blue one?
The blue one.
Yes.
So what you expect that in normal sinus reading, only the fast pathway is active. That you can see the label is sinus rhythm.
Yes.
The slow pathway never conducts down to the ventricle. Usually blocked. The reason it is blocked is because the fast pathway is faster when there's sinus rhythm. Okay? But when the patient now have premature ventricular contraction, what happens is that the fast pathway, remember, in the normal sinus rhythm, it has carried pulse activity to the ventricle. So it is still in its refractory period. So when atrial premature contraction occurs, it cannot pass through the fast pathway because it's in the
because that
refractory
one is
pathway.
the refractory period. So
Exactly.
it
So it will pass through the slow pathway. So the slow pathway will not take it down to the ventricle again. And by the time it is reaching the ventricle, the fast pathway is off the refractory period. Okay, so that is why it can now receive impulse, and that impulse will take it back to the atrium in a retrograde fashion. Are you getting this, sir?
Yes, sir.
So then that is what the circuit will now continue. So as it's going back to the atrium, the slow pathway will take it back and take it to the ventricle. And before getting to the ventricle, the fast pathway has taken it a retrograde fashion back to the atrium. So with that circuit, the same time you are depolarizing the ventricle through the slow pathway is the same time the fast pathway will take it very fast back to the atrium. And that's what will generate the AVNRT. Do you get it, sir?
I get it absolutely.
Yeah. So what I wanted to also notice that this, you can see in this picture, there's the sinus rhythm side and there's the premature atrial contraction. So it is the premature atrial contraction that degenerates into this sarcos motion. You get it, sir?
Yes, sir.
So meaning that on a normal day, if there's no atrial premature contraction, the patient will not go into the sarcos or reentrant activity. Okay? Now, and that is what is happening in Braunwald. If you go back to the Braunwald slide, that Braunwald question. Can we go back to the Braunwald question? The one Dr. Tony is showing. No, Dr. Tony, go back to that EP. That EP slide.
5, yes, I'm there.
No, the figure 2.8. The EP reading, figure 2.8. You've taken it from here. Yeah, I want you to notice something on that. So let's start from the beginning. You will notice atrial activity and the normal H and V, the first cycle. Okay? Dr. Ajayi, you are following?
I'm following, sir.
Yeah, you go to the second cycle too, cardiac cycle, you will notice the AHV, right?
Yeah.
Now, you will now notice that before the end of the second circuit, cardiac cycle, there was an A.
Yeah, very
was
close
not
to
conducted.
Yeah.
Before you now before the patient went into the reentrant tachycardia, the merge HAV. So that A you saw was the premature contraction.
Okay.
That was the premature activity. If you notice that A is close to the preceding atrial activity.
Yeah.
It didn't come at its expected time.
Yeah.
It came before. So that was the premature contraction that happened that degenerated into the circuit, AVNRT circuit.
Okay. Okay.
You get it, Dr. Tony?
Yes, sir.
Okay, so that's what's played out in this place. Okay, so we can go to the question and solve the question. Hope there's no question. If there's any question, let me know on this EP.
That's a little question.
Yes, sir.
Talking about the premature atrial complex.
Yes, sir.
Well, I think could it be that it was stimulated in EP labs?
Yeah, it comes limited in the EP lab.
So because I was wondering, the patient had APC while doing the study, or probably it was stimulated by this one. Now, was it stimulated to generate this preemptive tachycardia.
Yeah, it was stimulated. Can you see the pacemaker spike on the surface ECG?
I can see, yes.
No, take your arrow there. You can see that pacemaker spike.
Yes, yes, yes.
And the one before too.
Yes, yes.
Yes, and the one before that.
So that's
that's
the
what they try to
S1,
do.
okay.
Yes.
So that's the S1, then S2 bearing the.
So the S2 will have been the premature complex that happened.
Okay. And even the distance, first one is 500, then 250.
Yeah, so 250 telling you that it was a premature.
Could it be the circle, what do you call the SCL?
So that's the sinus cycle time.
Sinus cycle time.
Length or sinus cycle length, SCL.
Oh.
Remember, you are the one that chooses the cycle's length you're using.
Okay, that's what you say is corrected to.
Yes, you can be corrected sinus cycle length, yes.
Thank you, sir.
Okay, sir. Okay, so we can go to the question now.
And the answer is looking at us.
Dr. Ajayi, what would be the answer, sir? Question 225.
Question 225. Sample person from this not sinus tachycardia. It's multiple doctor. Typical stuff fast is the model. I heard now is C now, G. Wait to orthodromic AV oriented using an accessory pathway. AV variant. Chief is C. Now no doubt that's HBE this thing showing that both the polarization of atrial and ventricular, but I think it's C.
Yeah, so that's the correct answer, sir. You see. So we can move on now.
Yes, we can.
Okay. Question 226. A 75-year-old woman presents following an episode of syncope. She was watching TV with her husband when she suddenly lost consciousness and was unresponsive for approximately 20 seconds. She awoke slightly confused, but otherwise felt well. Her past medical history is unremarkable. The baseline ECG demonstrates right bundle branch block and left anterior fascicular block. An EP study was performed, and a panel from that procedure is shown in figure 2.9. So which of the following is the most appropriate recommendation? A. So before we go to the recommendation, let's look at the EP. Figure 2.9.
Dr. Ludi, you may explain this one before.
Dr. Adebowale, what do you think?
Okay. It looks to me like some form of dissociation with, I'm not sure. Let me get it right first of all. So my confusion here is the distal, mid, and proximal hiss. Which of the readings are we going to take? Because I can see the right ventricle as tracing.
Yeah, fantastic.
And on the right ventricular, on the proximal hiss, I can see, I think there's an atrial, there's a ventricle. It's not, it doesn't look, it looks like a dissociation to me. But I'm struggling with the waves on the distal hiss bundle.
Okay.
On the proximal hiss, it looks like there's some dissociation, but on the right ventricle, I can see the QRS. the waves there. And yes, I think that's what I can say. I'm not sure, but that's what I think.
Okay. Fantastic. Okay. So now I also want you to notice something on the RV lead, the RV catheter. What did you notice? Look at the rhythm on the RV catheter.
Okay, that R wave appears slowed.
No, I'm not talking about the surface issue. I'm talking about the
Right
EGM.
ventricular pressing.
Okay.
There is like a there is this after the second there is a skipped beat here. There is a skipped contraction. Expecting a spike where there is no spike.
Fantastic. So, Dr. Adipol, you can notice something about the intervals between the RV. Look at the distance between the first deflection and the second deflection.
Right.
You don't bother about slurring on EGM.
Okay.
And remember, Dr. Tony was asking us that can the shape of the EGM tell us if it's RV or RA? I said no, because it depends on the on how you filter the catheter. So compare the shape of this one now, 2.9, to the shape of the 2.8. You can see they are far different.
Yeah.
So it's not a shape that will tell you if it belongs to RV or not.
Okay.
But the catheter will tell you what is happening. That is why it's always good to have both an RA catheter and an RV catheter. An RA catheter will monitor the atrial deflection for you. You'll be able to distinctly tell that this is atrial activity. That's the only thing it's going to record, just like we have in 2.8. Like in 2.9 now, you have a RV catheter.
No
and the only thing it's going to tell you is ventricular activity. It will not mix activity for you like the East bundle catheter. You get it, man?
I do so.
So, but since we don't have a RA catheter, it will be difficult for us to tell you which one is atrial activity or which one is ventricular activity. Are you getting me, man?
I am, sir.
But let's tease out what we have. We have the RV catheter. But there's something about that RV. Look at the history of the patient. She passes out. Now, let's look at the RV activity. You will notice the first deflection in the RV catheter. You notice the second deflection, right?
Yeah.
Look at the distance, the interval between both deflection. Now, compare it to the third deflection and the fourth deflection. What will you interpret out of that?
The distance between the third and the fourth deflection is about twice the distance of the first and the second.
Yeah, so we notice that, Dr. Tony, you can help us put your arrow in between the second and fourth. Chief Tony.
Yes, I'm here.
Okay, I'm looking at something else.
You can see the arrow.
So you can see that there is a missing activity, Dr. Adeboale.
Yeah.
At that point of the arrow. You notice?
Yeah.
So that's the point at which it passes out.
Right.
So that missing activity, it could be, you might not be 100% sure, but it likely looks like a Mobit type.
Yeah.
And we'll tell you why. Although it's difficult to tell since we don't have the RA activity. If there was the RA activity, I can link RA activity to RV activity and determine if there's progressive prolongation.
Hello, Chief. Sorry, please. I don't know if I can just speak. Hello, sir.
Yes, sir.
You can hear you. Go ahead.
Sir, what about the way the proximal is in between the RV activities of the ventricular activities or something? There is this way that is not his proximal.
Yes.
It appears that his proximal is picking some atrial activity that's not conducted.
You are right. I'm not saying it's not. Hello, Professor. So I'm not your background.
Microphone needs to be silent.
So, Chief, so what I'm trying to emphasize, Dr. Kopi, is that yes, the East activity is picking some atrial activity and East bundle activity. That's the proximal East. Even is present in the mid East, is present in distal East. But the question is, it will be difficult to tell if I don't have a RA catheter. If I had a RA catheter, unlike the figure 2.8, there's an RA catheter. Abi?
Okay, I get it now.
Even if they did label, even if they didn't label H not the RA catheter, I can tell you that okay, any catheter, any deflection that corresponds with the East bundle deflection is the atrial activity. And you have a RV catheter, any deflection that corresponds between the RV and the East bundle catheters, then is a ventricular activity. All I can tell you from this EGM is that the RV catheter, which is recording ventricular depolarization, we can see the representation on the proximal East. We can see that same representation on the mid and distal East. So you can put your arrow there so that you can follow. I'm so sorry, but there's no the NEPA here, no got light. So, Chief Tony,
yes,
are with us?
I'm with you.
Let us shift your hair. You see your arrow now is on the RV catheter, RV deflection.
RV, this is okay.
Yes. If you move it up to the proximal East, you will see it. You will see the same RV activity, right? If you move it to the mid East, you will see the same RV activity. And if you move it to the distal East, you will see the same RV activity. Okay? Can you see?
Yes.
But it will be difficult to tell you for the, so let's move to the deflection after it, the little deflection after the distal East. It's difficult for me to tell you which one is this, except I want to form for you. If I don't have a RA catheter, it's difficult for me to tell you what wave we are seeing. Even in the EP's lab, it's be difficult, except there is an RA will tell you that if I have a RA catheter, I can tell you maybe that is a atrial activity. But if I don't have a RA catheter, I will just be forming for you. But what activity I can tell you that there's an RV activity here. And I can trace the RV activity up. And now I notice that the RV, if we now look at the interval between the individual RV, there's a missing RV activity in the third, between the second and the third, there's a missing RV activity. I hope you are following me.
Yeah, I'm with you, sir.
Yeah, so that is the cause of our passing out. Okay.
Significant that the amplitude of the RV catheter, also the amplitude of these waves.
I didn't get you clearly. You sound distant, sir.
Yes, sir.
You say something, sir.
No. Chief, can you hear me?
Yeah, I can hear you now, sir.
Chief, I'm saying that if we look at the RV tracing, the amplitudes of waveforms, they also seem, the amplitudes seem different. That is it of any importance at this point?
No, it's a filtering.
Okay. Okay.
Don't
Hello, hello, Chief. Sorry.
Yeah. Okay.
Chief, I'm very sorry for bringing you back here.
No problem.
If you look at the surface ECG of the P1 of the QRS complex, you this suggestive of a block? Something like that. It's looking like there is a block there. I don't know. Maybe that's what they're trying to do.
But that's what we're saying. There's a block. As in, that's what we're looking at the interval. There was a missing QRS complex. Dr. Kopi, that's what we are trying to emphasize. And that's why the reason the patient is passing out. That's why we're saying that this looks like a Mobius type 2. Okay.
Maybe just to also add something, let's not also forget the history. He said this patient have RBB and have left a kind of bifascicular block from
That's a
the
bifascicular block. Fantastic.
So the age and having bifascicular block is something more infranodal. So something more like in the his or the branches. So which also will support Mobius type 2.
Yes, sir. So, Dr. Adebale, what will be your treatment, man, for this patient?
Sorry, Chief, just before we go to treatment, I wanted to just make an observation on this EGM. If I was just looking at his activity now, combining all together, irrespective of whether it's distal, mid, or proximal, I can see that there's his activity, whether at the distal, whether at the middle, whether at the proximal, has a form of his activity. That means that there's a conduction through the AV node to some degree, even though we're not able to say exactly whether they're recording the atrium or the ventricle. But we can say that there's a conduction in the his bundle branch or AV node his bundle branch, because we can pick some activities around there. But there is no conduction, like we said already, through the ventricle because of the drop after the second electrical activity on the ROV. So could it be that this patient had activity conducted across the AV node, got to the his, but it was not conducted because of the block the patient is having to the ventricle?
Yeah. That's why we
So
said the patient had Mobius type 2. No?
That is a Mobius type 2. Okay. Yeah. So the term we're using Mobius type 2 now because it's more is a problem. The conduction is an infranodal impairment.
Yes, sir.
So how are we going to differentiate this from Mobius type 1?
Mobius type 1 is nodal.
Is more nodal. Okay. Yeah, that's what I wanted to just say.
That's number one. And Mobius type 2, you see progressive prolongation, which we have not demonstrated on this case.
Okay. So, question.
Dr. Adebale, is it clear?
Yes, sir, it is.
Okay. I've not even heard. Dr. Adebale, I think she has logged out. Okay. No problem. Okay. Shall we move on?
Sure.
Dr. Okopi, shall you agree with us? Dr. Julius?
Yes, sir.
Okay. Okay. And Dr. Akpan, Dr. Bernard, I salute you. Okay, we are looking at, so what's the answer now?
The pacemaker.
Dr. Ajayi?
Question 226. Yes, I think we're on 226.
Yes.
I'm trying to open to the page. It says, okay, so they say, which of the following is the most appropriate record recommendation. A, catheter ablation for AV NRT tachycardia. B, beta blocker therapy. C, neurologic consultation. D, permanent pacemaker implantation. E, coronary angiography with anticipated percutaneous neovascularization. So for a patient with a block, is it not pacing? It can be beta blocker now. Well, a patient we get block, we can't beta blocker. It looks more like pacing to override the block.
You're correct. You're correct, sir. You're correct, sir.
Thank you. Okay. Thank you, sir.
So we can move on. So question 227. Dr. Jaya, I hope I'm audible, sir.
Yes, sir, live and clear.
I didn't see your friend, Dr. Blessed. Let me greet him. So all of the following statements about distinguishing VT from SVT with aberrant conduction in a patient with Y complex rhythm are true, except. So everything is true except differentiating VT from SVT with aberrancy. A, the presence of fusion beat supports the diagnosis of VT.
That's true.
Yeah. B, termination of the tachycardia during vagal maneuver is consistent with SVT.
True.
That is also.
Difference of AV dissociation implies VT.
True.
True.
Okay, good. D, concordance of the QRS complex in the precordial lead is more suggestive of SVT than VT.
Yeah.
A lie. It's the other way.
Thank you.
Not suggestive of VT.
Fantastic. Then that is Brugada criteria.
Yes.
So E, a part of MI makes the diagnosis of VT significantly more likely.
True.
Yeah. So D is the odd
So
one
is
out.
so B is the odd one.
Yes, D is the odd one. So question 228.
Okay, because before you go forward, just wanted to make a comment about the last stuff. Sorry that I'm taking you guys back. I stepped out before, so I wanted to make something.
No apologies. No apologies, sir. It's all for our learning.
Something remarkable is the fact that this patient had an ECG done and had bifascicular block. I'm sure in the clinic usually would, okay, because she also has syncope, we want to recommend for pacemaker. But I'm also quite amazed because doing the EP now, we now know exactly that this is module step 2. You know, so that means if I've not done the EP, we won't be able to say exactly. We'll have seen just based on the recordings of ECG. We'll just end by saying that this is bifascicular block. So that means that the EP study will give us more anatomical location beyond just functional location from the ECG. So I was just trying to make that observation that I wish we can be doing EP studies for our patients. It's very good.
You're correct, sir. That so not all bifascicular block are common or benign, especially when they become symptomatic. That thing is not benign. Okay. So hope I'm audible, Chief.
Very audible.
Okay, thank you, sir. So a 53-year-old, we're in 228 now. A 53-year-old man with symptomatic AF presents for elective outpatient cardioversion. For the past 3 months, he has been taking appropriately dosed rivaroxaban as an anticoagulant and diltiazem for rate control. Which of the following statements about external electrical cardioversion is correct? A, Admission of intravenous ibutylide before electrical cardioversion facilitates successful conversion of AF to normal sinus reading. B. Electrical cardioversion is most effective at terminating tachycardia that arises from enhanced automaticity. C. Repeated shock at the same energy level increases chest wall impedance. D. Rivaroxaban can be safely discontinued 7 days after successful cardioversion if reading is achieved. So what will be your answer, sir? Hope I'm audible. Hello?
You are.
Okay.
We are looking for the one that is not the one that is correct. I think
We
A
are looking for the correct answer.
correct answer. Would obviously B is not correct because it's effective in terminating reentry tachycardia mechanism.
Correct.
C is also not correct because the repeated shock at the same energy level, maximum energy level, will reduce chest wall impedance, not increase. So rivaroxaban can be safely discontinued 7 days. I don't think it's safe because mechanical activity usually lag behind mechanical activity. So even when you have converted the patient, there will still be some stasis and all that. So you may need to give it for more than 7 days. So the correct one, I think, is A, admission of intravenous ibutylide should be class 3 active medication. So it is facilitate because it will prolong repolarization. So it will facilitate the conversion of AF to normal sinus rhythm. That's the correct one.
Yeah. Dr. Ajayi.
Dr. Ajayi, are you still there? I think he's still here.
Antiarrhythmic agent. So A is the correct answer. Okay. Question 229. Hope we can move on. Question 229. Each of the following predisposes to arrhythmia shown in figure 2.10, except. So let's shift on. You can help us go to figure 2.10. Hello?
Hello, sir. Can
Hello?
hear you. We can hear you.
Yeah. Figure 2.
Okay, 2.9.
You said each of the following or 2.10. Can we go to that figure?
2.9. 2.10.
2.10. Okay. Dr. Ajayi likes this a lot. Chief Ajayi.
Dr. Ajayi, are you there?
Yeah, I'm here, Chief. Sorry, I went to drink water.
Dr. Eneche.
Okay. Chief Ajayi. So what do you think of that?
2 point waiting, Chief.
2.10 is there on the Zoom.
2.10.
It's on the Zoom.
This is Tossards now. This is Tossards now.
Yes.
This is Tossards. usually due to QT prolongation. Polymorphic ventricular tachycardia.
Sorry, I didn't get you clearly. My network went off. You said
I
it was,
said this looks like torsades.
yes,
A
torsades.
form of polymorphic ventricular tachycardia due to
Fantastic.
QT.
Fantastic. So they said, so the question says, question 229 says, each of the following predisposed to dysarrhythmia are shown in figure 2.10 except A, congenital severe bradycardia, B, hypokalemia, C, loss of function mutation of SCNF5A gene, D, tricyclic antidepressant overdose, and E, disopyramide. So what will be your answer, sir?
Chief, I know tricyclic causes torsades, predisposed to torsades.
Yes, sir.
I know of hypokalemia and other dyselectrolytemias. So B and D are already out of the equation. Disopyramide. I'm not sure. This congenital severe bradycardia. I know that Romano Ward and Javel Lang Nielsen have been waiting with that job-breaking name. You know, I know there are also congenital forms of causes of torsades, but severe congenital. Chief, that's A is suspicious. This
No, I don't think so. Severe. If there's severe bradycardia, the ventricle will take over. Because the way that severe is the range of, let's say, less than 40, 30, 20.
Okay, if it's true, the ventricle will take over. So it's rhythmic. Okay, that's a beautiful way of looking at it. Thanks. So that means the option is now between this C and E. Now, this SCN5B, it has to be disopyramide because I know I've seen this SCN5B. Is it not a channelopathy associated with Brugada?
And this is so yes, as with Brugada, when there's loss of function.
Yes, it's a channelopathy.
When there's gain of function, gain of function can be loss of function.
Yes, so it's disopyramide that is the odd one out.
No, I don't think so. Disopyramide is in class 1A. Yes, class 1A, that prolonged refractive period. The same thing hypokalemia will do. That's what disopyramide will do. So the ventricle can take over. I would rather go with C because this loss of function is found in Brugada system.
Yes, but Brugada is associated with sudden cardiac death now.
But not with, don't say the point.
Okay. No, I don't get lost. We are talking specifically of torsades.
Yeah, that's what torsades. That's what we're talking of.
They just brought another arrhythmia and inserted it into this thing. I concur with you, sir. It's likely to be C. It's likely to be C.
Yeah. So don't forget that all the class 1 antiarrhythmic can also give you torsades. They can give you prolonged QT and torsades. So disopyramide is one of them.
Okay.
Yeah. So Brugada will actually give you ventricular fibrillation and cause sudden death.
Thank you. Yes, ventricular fibrillation. Oh, you see, that's the issue. They put this question in such a way that one is mixing up one arrhythmic condition for another.
Yeah. You know, their question is the second order of questions. For you to answer this question, you should know ECG findings of torsades. You should not know the etiology of torsades. So they're asking you two questions in one. Second order of reasoning.
Wickedness in high places.
I pray Dr. Kiala will not ask this kind of question.
All right, 230.
Yeah. So 230, we'll move on. The question says, a 60-year-old man presents with presyncope and is found to have a wide complex tachycardia at 140 beats per minute. So first is presyncope, wide complex tachycardia at a rate of 140 beats per minute. EP is performed and tachycardia is induced as shown in figure 2.11. The mechanism of this tachycardia is AV reciprocating tachycardia utilizing the accessory pathway, AV NRT with aberrant ventricular conduction, VT atrial flutter with aberrant ventricular conduction and sinus rhythm. You got 2.11.
0.11.
Figure 2.11.
Okay.
So, Chief, what do you think?
Oh, wow. I'm trying to understand this thing. Right ventricular apex, his proximal, his distal. HRA. What is HRA? Right?
High right.
High right atrium. Okay. Chief, me, I'm lost though.
Okay.
Because this, if I'm looking at the right ventricular apex, the interval, it doesn't look like it's even tachycardic. It's so widely spaced. I don't know how to interpret this one.
Okay. So I want you to know that in the EP lab, you can space it as much as you want.
Are you serious?
You can broaden the whole thing. That all you need to do is the same thing you can do on your echo machine, and the same thing you can also do on the surface ECG. All you need to do is adjust the sweep speed. I'm sure you always see on your ECG. There's always what they post 25 millimeter per second.
Yes.
You notice on the ECG. So that's the sweep speed. You can actually make it wider than, you can increase it to 50 or 100 millimeter per second. And you will see that your QRS will be broad. And that's why if you look at your ECG, there's usually a reference ECG. When you print out the ECG, there's always one segment that shows a reference for each lead. 1 cardiac cycle.
Yeah.
That it will become wide. If you notice that they will broaden the QRS. Because the swift speed of that is around 100 millimeter per second. That's why it looks that wide.
Okay.
So that's the same thing you can do in EP lab. You can just increase the swift speed and it will make the QRS complex wide. Okay? And the interval, the duration will be far from each other.
Okay.
Because so Chief Tony, let's put an arrow as you are doing.
Okay.
So this is the easiest way to interpret this. Let's start from thank God they gave us HRA. They gave us the RV. So you can use both of that to interpret, and you can also use it to interpret your EAS activity, like the proximal is now. So you notice that the HRA deflection, as I said, we only record deflection for right atrium, right?
Yes.
The RV catheter, we only record deflection for ventricular. Are you getting it? Okay. Why the EAS catheter will record activity for both? including east bundle activity. Now, so let's do some tracing first. Let's focus first on HRA and RV catheter. Then later we'll come to the east catheter. So the RA, you can see the HRA catheter, sir, Dr. Tony.
Yes,
HRA
sir.
catheter. So you can see the first deflection to show atrial activity, right? You will.
Yes.
So let's go again. Let's go and see the next deflection to that. Can you see the next deflection to that? Then go to the next deflection to that. Now, just focusing on HRA. Dr. Tony is already putting his arrow. Are you on the Zoom?
Okay.
Are you seeing Dr. Tony's? Yeah, you have to look at Dr. arrow. So, so Dr. Tony, let's start from the beginning again, so that you would see Dr. Ajayi can follow. I'm not hearing that person's voice, so, and
yes.
I'm not sure if everybody is actually really.
Yes, I see that.
We are 12.
Dr. Julius, is it clear? Dr. Akman.
Dr. Akman.
Dr. Fino.
Caroline. Dr.
Duduyemi did not even say anything.
Duduyemi is just sleeping today.
Okay. We say hello to all of them.
Yes, I see the first deflection there.
Yes, you can see the first deflection. Dr. Tony's catheter is
yes,
arrow is on it. Now go to the next deflection after the first one. You can see.
Yes. Yes, sir.
Then go to the next one, Chief. You can see that deflection. Fantastic.
Yes.
That's first one. Let's go to ventricular activity. So we see the first deflection of ventricular activity. We see the next deflection.
Yes.
I want you to take note of the distance between each other. Compared to the distance of atrial activity.
It's closer than the HR.
Atrial activity. Fantastic. That's number one. Number two is that you would expect that the atrial activity should be close to the ventricular activity also. Right?
Yes. Ideally, yes.
As in there should be at least an interval, is a constant interval. So, Chief Tony, you can put your arrow first on the first atrial activity. Then want to compare that activity to when you got the ventricular activity to compare the interval. Yes, you can see the interval, Dr.
Yes,
Ajayi.
sir. Yeah.
So let's go again to the next time you saw atrial activity. In the next slide, there is a missing atrial activity, but you can see the next time you saw atrial activity.
Yes,
and
because
compared to the interval to the ventricle,
it's different.
It's constant. It's different, right? Fantastic.
Very different. And in between, there is ventricular activity.
Exactly. And by the time you go to the next atrial activity, you can see how close it is to the preceding ventricular activity.
Very, very, very.
So there is progressive prolongation.
No, so the first thing is that there's no relationship between the atrial and ventricle.
Okay.
Okay. Yeah.
Because you will notice that even there are some cycles where you can't even see atrial.
Yes.
And you are seeing ventricle.
Yeah.
Okay, that's number one. So remember there was a time Dr. Tony was asking, or someone or colleague was asking about using the East catheter. Why can't we follow the activity on the East catheter? Or to decide what is represented on the East catheter. So now, if you look at, I can say atrial activity, right? I can trace it to the proximal East. Dr. Tony, you can trace it to the proximal East.
Proximal East.
Yes.
So so I want you to relate that atrial activity to proximal East activity. So you can see that. So that would be a P activity, atrial activity. Can you see it on the East catheter? So you can see if I don't have an atrial activity, it will be difficult for me to tell you that this deflection is atrial or this deflection is ventricle.
Yeah. Very
You
true.
get?
Yes, sir.
Or else we'll just be assuming. Look at the
Mm.
RV apex now. RV apex activity. Compare it to the East catheter activity. Yes, that one compared to the East catheter activity.
So the is
The proximal is. Yeah, the proximal is. That's a small deflection. No, just come
Very
back a
true.
little. Come back. Yeah, that's that
Yes,
deflection.
one. Yeah.
You get? So
Mm.
so just to emphasize that it will be difficult to tell which activity on the East catheter if I don't have an RA and an RV activity. Or else I'll
Okay.
just be assuming.
Okay.
If you go to the next one now, go to the next, sir, the next RV apex activity. Yeah, you can compare it to the East activity, proximal East activity. You can see it now. You can see that the shape looks similar to the previous one we saw.
Mm-hmm.
Now, you will notice that in this side, you cannot see HL activity at all. Why? On the proximal East, you didn't see HL activity on the proximal East because the RA catheter above did not show any activity.
Yeah, it didn't.
It didn't. Yes. And by the time next time it was showing, you can see what is proximal is activity is.
Yeah, it's also showing.
So you can
So
see that
that's
I just want to use this to emphasize that if without an RA catheter showing atrial deflection, you cannot tell on the East catheter which one is H, which one is A.
Okay.
Dr. Tony, hope you are getting that now.
Yeah, very well.
It's always good to have an RA catheter, then RV catheter, then you can now use the East catheter as your reference and tell that this one corresponds to this one corresponds to this.
Okay.
So it's clear cut that there's no relationship between the HRA and the RV. The AHA activity is coming at its own regular time. If you time the interval, although it's not coming at expected time, but it is regular. If you notice.
So it's a form of bradycardia.
So you'll have, yeah. But look at the RV too, it is coming at its own regular time, but it's not related to the HA-RA. Okay. Now, they now said, so Dr. Ajayi, you agree with us that there is AV dissociation. There's no relationship between the atrium and ventricle.
I agree, sir.
Now, they now said this patient had a rate of 140 beats per minute and is wide complex from the question. Okay.
Yes, sir.
So what would be your diagnosis?
Wide complex tachycardia.
With AV dissociation on EP. What would be your diagnosis?
It doesn't fit atrioventricular reciprocating. It doesn't AV nodal, no, it's not that. VT, that is very suspect. Atrial flutter with aberrant, no. Sinus tachycardia. No. Sinus tachycardia would be narrow, not. So it's, Chief, I'm suspecting is between C and with aberrant ventricular. It's between C and D, but something tells me it's more of C than D.
Because you ask yourself, okay, we just add in question we are in 230 now.
Yes.
Right? Remember in question 227, look at option C in 227.
227. The presence of AV. Ooh, Ezioku. Yes, so you see. You see.
You can see.
See. Yes.
So that's how to detect that. Dr. Tony, hope you are with us, sir.
Yep.
Yes.
I did hear Dr. Kopi's voice again. Let's say get flights for tomorrow. Okay.
2:30. So,
So
Chief, if anybody is sleeping, are we still going to? How many people are responding now? Let me check.
nobody is responding.
It's just 3 of us that are talking, but they will get the record.
Chief told me. Okay, so
It seems sleep has been knocking seriously on. Even Okopi has gone dark.
All of a sudden.
Okopi is preparing for flight. Okay, 2:31. We'll end in. Maybe we should just end the 2:35 for their sake.
Okay,
Just
sir.
end it to 2:35.
Okay, sir.
Yes, sir. So which of the following statements is correct regarding the EP SLS such abnormality depicted in figure 2.12?
CP, their
Yeah,
main
2.12.
number.
This one, they are giving us expo.
We have right atrium, we have his
But the expo did this one. Though.
Which of the following statements is correct regarding the abnormality?
The expo, they look at you for front like this.
Let me see. Electrophysiologic abnormality. So what is the abnormality now? I'm seeing, okay, here's the atrium. That's the hip. Then the ventricle follows in the first cycle. Then again, the atrium, the his, the ventricle, but they're looking crowded here. Then the third one, the atrium, the his, the ventricle. Chief, I'm thinking how am I going to interpret it now? Chief, I need push small. The keke don't stop.
No, they don't give you expo.
What's
Inside
the
that thing. How many times have you been seeing figures?
Oh, let me see, 240, 280. So it's widening. Hey, can you imagine? Eyes when no they see. It's widening up to even 325 here.
Then what now
So
happened after that 325?
after 325, there was now like a pause. Yeah, there was like a but no H and V.
There was atrial depolarization.
But no.
After that 225, you see this bundle activity, see ventricular activity. All of a sudden, we're seeing atrial activity. So probably this ventricular activity depolarized the atrium, a kind of accessory pathway. Kind of. Then
I want you to. No, I don't want you to go in that line. Okay. I want you to look at. They gave you AH. What does AH interval represent?
You know the activity.
AV node interval, yeah. Right? AV node. Yeah. So look at the interval again. What does it suggest?
The interval has been widening.
Yeah. What condition will give you that?
It's a block, Mobit type.
Exactly. That is Wenken-Backing.
Yeah.
It was progressively increasing. That's what I said. They gave you expo. We can give you. They are giving you time that.
Chief, I don't look the figure. I was seeing plenty alphabet. I don't look the figure.
You understand? Until you now got an atrial activity that there was no conduction.
Conducted. That's
then
towards the end.
Back. Exactly. Then it shortened back to 240. And if you continue to take the reading, you will now notice that you go to 280, 290, and until it drops again.
Mm, yes. When
Okay.
Quebec phenomenon. Yeah.
Yeah. So we can now answer the question now.
Okay. It is associated with syncope and sudden death. When Quebec, I don't think so. No, maybe true. When present with an inferior MI, it is an indication for temporary pacing. When present with an inferior MI, when Quebec, make I just put question mark over that one. It typically reflects block
If you know
the
that is
length of the AV node proximal to the his bundle. Yeah, I think when Quebec is proximal to his bundle, the other one is
Exactly.
distal. So this looks like a true statement. Carotid sinus massage. No, now that one is for SVT. So
So
it looks suspiciously between C and B, but this statement, indication for temporary pacing. It looks, I don't believe it. Oh. I don't believe it.
do you pace working back?
When back.
Do
No,
you?
now. No. Thank
Okay.
you. Why wasn't I?
So,
If you like, yeah, you're
so
right,
let's
Chief.
move on.
It's going to be C.
So let's move
Yeah,
on.
232.
232. For which of the following
Yeah.
patients is permanent cardiac pacing not reasonable therapy? Not a reasonable therapy. A. A 35-year-old with asymptomatic type 2 second degree AV block and sinus bradycardia of 38 beats per minute.
No.
B. A 70-year-old man with left ventricular hypertrophy, persistent fatigue, and lightheadedness with marked first degree AV block with a PR interval of 0.36 seconds. A 57-year-old man with acquired asymptomatic third degree AV block. D. A 40-year-old woman with asymptomatic congenital AV block. And E. A 50-year-old marathon runner with calf cramps and 3.4 second pulse during sleep.
3.4 second pause. Waiting be that now.
That's 2.4 second pause. That's there's a pause. Marathon. Marathon run.
As an athlete.
As an athlete. You will die.
With calf cramps. Calf cramps. Are they trying to draw a mind to claudication of But anyway, the question is that we will not need permanent pacemaker. I know A needs permanent pacemaker. This PR interval is prolonged though. It's 0.12 to 0.20. So this patient needs spacing. C, acquired asymptomatic third degree AV block needs spacing. Then asymptomatic congenital Chief, we don't need to look far. It's E. What concerns
He's an athlete now.
He's already run.
Easy. That's the only person that you know give.
Yeah.
Okay.
That's
233. A 62-year-old woman underwent pacemaker insertion 4 years ago because of marked bradycardia. As part of his exercise program, he has been using a rowing machine. Recently, he has had several episodes of near syncope that have occurred only during such exercise. That means when he was rolling the machine, the rowing machine. Okay, an ambulatory ECG Holter monitor demonstrate the reading strip shown in figure 2.13 during one near syncopal episode while rowing. Which of the following is correct? So 2.13.
We have come back. We
Sir?
have come back to DDD. VO.
2.13.
Yes. We're there, right? We're there, 2.13.
Hmm.
Okay.
So what's your diagnosis? Chief Ajayi.
Chief, this person, I'm seeing AVF, the first and the second are fairly okay. The third is where the problem starts. In fact, with the third, after the third, I don't know whether it's artifact or whether it is, I don't know what it is, but there is something, there was like a pause, flat line virtually, because we can't have any discernible activity there. And then there is activity, cardiac activity again. So I don't know how to interpret what happened in that interval between the third cardiac activity, third cardiac cycle, and the fourth. I don't know how to interpret it. What is even what they are asking, Seth? They say, she is 233. They say, which of the following is correct? There is evidence of a single chamber pacing system. There is inappropriate inhibition of ventricular pacing. There is undersensing of atrial activity. There is lack of capture of the ventricles. There is lack of capture of the atria. Capture is when, but they are normal. There is capture now because I'm seeing normal, at least almost normal looking, at least the first and second. So there is capture of Chief. This answer lies between, it's just that this issue, I don't know how to analyze this issue of single pacing, and is between
From what I can see,
ABC.
from
I'm
what
trying to, yeah, go ahead, Chief.
what I can see, if you look at what they get to DDD 70 beats per minute,
Yeah.
it says meaning both atria and the ventricle are decreased, and both atrium and the ventricle are also decreased. So that's what we can see. See the pacemaker activity here for atrium, here for the ventricle. Then same thing for the next cardiac cycle length. And same thing for the third cardiac cycle length. So it is after the third cycle length. These appear to be, I think those are like, I'm seeing some pacemaker activity inside. I don't know, look like an artifact though, but I'm seeing some pacemaker activity. But if you leave that with, you come back to the ventricle again, you see an activity, another. But the pathology is after the third one, like you rightly said. I can't see there is any activity. So this, they say, which is correct. There's evidence of single chamber pacing. That's false because it is dual chamber pacing or DDD. So there is inappropriate.
Of course, narrows it between B and C. Okay, thank you. You're right. DDD.
There's inappropriate inhibition of ventricular pacing.
Inhibition of ventricular pacing. I don't even understand that.
You know,
Inappropriate.
the DDD, this last D is either you are inhibiting ventricular pacing or you are pacing, you're actually pacing or you are not. So there is this pacemaker thing again. Okay. I think I need to just put some lights. Trying to remove
Yes.
this.
Chief, come
Yeah,
to the
so-
rescue.
No, so you can see that he paced the first cycle with
Yeah.
a P wave that was generated and another pacing generates QRS. If you widen your screen very well, you see a pacing spike in front of the QRS.
Yes.
So the same thing happened for the second cardiac cycle and also the third cardiac cycle. But you now notice the artifacts, as you rightly said, at the baseline.
Yeah.
So, but you notice that there was no pacing in between the artifacts, if you notice.
Oh.
And compare the distance between that condition, that third cycle to the fourth cycle, you can see that the time was more prolonged.
Very far.
Okay, so it means that the pacemaker machine was sensing intrinsic cardiac activity with that baseline, thinking that that was ventricular activity. And so it was now holding back. It was inhibiting pacing. That's why you not see a pacemaker spike on that artifact. You know that I didn't see a pacemaker spike on it.
Yes.
Because it is sensing it as if it's a normal intrinsic activity.
Okay.
So that's why they not pace.
Like they're using the artery to do surgery for the patient.
Something like that at that time.
Okay.
The baseline and still have artifacts.
The patient will go into assist if nothing is done.
Correct. So we can now answer the question, I mean.
Okay. So it looks more like this issue of there is undersensing. I know the answer is between B and C now, but the issue is how do I answer this issue of undersensing of atrial activity?
Undersensing means that it's going to be pacing. It means that it's going to be pacing on a normal QRS. Instead of normal QRS has happened and it should inhibit pacing, it will not sense the intrinsic activity of the patient. It will pace on it. That's undersensing.
Okay.
You understand, sir?
No, I don't, Chief.
It shows that. Okay.
Maybe just you watch our video. What do you think?
Yeah, actually, he has to watch that video so that
there's a video on. I think
that should be the last. It was the last one.
No, before the last one.
The one before the last one, yes.
Yeah,
Yes,
you know,
the
you
one before the
started
last one.
before the last one. We need to watch
But
that.
you need to watch it.
Okay, no wala. I'll watch it. Thank you, Chief.
Oh, can we rest?
I think it's the rest.
Let's I beg. Make engine no knock.
Chief Ajayi, it's good to hear your voice, and we missed you in our sessions.
Thank you so much, Chief.
You didn't come to back up.
I was sent.
Hello, hello. Yes, sir. Are we done?
Chief Okofi, don't miss your flight tomorrow.
No, sir. I will call you when we're getting up.